So I'm Isabel Smith. I'm one of the consultants here. I work in anaesthetics. So my day job this morning, I was looking after children having squint surgery. I do bowel cancer and bowel operations with surgical colleagues, and then I work over in maternity at Poole. I'm also working on the transformation with Richard Renaud and the rest of the execs and the medical directors and clinical teams. So I'm really pleased to be here today. Some of you will have followed these changes really closely. Some of you may be newer to it, so I'm going to just go through really what we're getting up to here. And it's really lovely to see people back face to face after a challenging couple of years. So the first thing I wanted to say really is that our intention through all of this is to deliver really high quality care to our patients. And this is clinically driven. So when we are planning what we're doing, we're involving our clinical teams. So not just doctors, nurses, allied health professionals, and also our bigger team of governors, patients, and others, other members of the public. So colleagues are creating new clinical pathways really to try and develop the most effective care for our patients. And I'm sorry, I had a line on the last thing saying the CSR is still valid, and I would say it's actually valid more than ever, because that intention to create an emergency site and a planned care site, I hope I will be able to explain to you, will really benefit our patients, particularly after everything that's happened in the last couple of years. So Siobhan's mentioned the ICS, and how does this all fit into that? And as she said, really, as we know, our patients don't just come to our hospital, have some care and then go away again and we forget about them. There's a whole pathway from being well at home, being kept well, and then developing some problems, seeing perhaps GP or someone else in the community, coming to use our services, maybe using services in Southampton or elsewhere. So it's a really complex system. And as Siobhan has said, the Integrated Care Board are trying to also maximise really use of resources and staff so that our patients get the best quality care. So the benefits, the original CSR set out these benefits of having a planned and emergency sites. And I suppose I would draw your attention to the situation we have at the moment, which many people are aware of, is that with COVID, we have had to manage across both hospitals a high number of patients in the last couple of years, both with COVID and other medical conditions. And that has, on occasion, taken up beds that we would like to use for our planned care patients. So that's patients having perhaps non-cancer surgery like hip replacements, knee replacements, hernia repairs. They've in some cases been delayed or needed to be cancelled so that we can manage our medical patients. So we're looking to separate that out completely and have our planned care at Poole Hospital with a focus on that elective surgery, shorter time to treatment, have the correct staff there so that the patient can come in, have their treatment, have their post-operative care and then go back home. Whereas here will be our emergency hospital, and again we'll have everything here on site. So I was talking to this chap earlier and trying to explain that sometimes at the moment you could come in, say you have a heart attack and you go to Poole Hospital, as Harry will be able to tell you, you'd be treated really well in the ED, you'd go to ward, but then you'd be transferred here because this is our heart attack centre. If you have a testicular torsion, our urologists are here. So we're really trying to make sure we have the right care in the right place. So more broadly, across the NHS as well, it's about coordinating teams and ensuring that our workforce are used in the most effective way, because in some cases we've got doubling up of workforce providing the same services on 2 sites at the moment. So looking at our sites, we have 3 hospital sites at UHD. Since the merger, we've had university status, and the ICS has been developed to try and improve population health and, as I say, keep patients well. But when they're not well, we provide care to a huge number of people with a wide variety of specialist services across the hospitals. So this is our journey so far. Makes it look very straightforward, which I don't think it has been for any of us. And we're currently merger completed, and as has been mentioned, we've managed to keep the momentum going around our transformation and still move forward with our business cases to attain a massive amount of money from the government. So over 200 million to provide the beach building and the new theatres at Poole, and then through a different funding stream of the NHP, we're looking to achieve another large tranche of money to deliver the rest of our plans. And we haven't put COVID on this slide, but obviously COVID has impacted in the middle of that, and we've had teams really working in the background very hard to keep these plans on track, but also to sense check them. Does it still work? Do we have the right number of single rooms? Have we got the right setup both within ED and critical care? If we had another pandemic, can we separate patient streams? So we've gone back over our plans and sense checked them. So I mentioned the new hospital programme, and that is funding a broad range of other works apart from the big builds that you see across our 3 sites. So looking at the buildings, Siobhan's shown this already. We've got the beach building at the front of Bournemouth Hospital, which will have maternity, ED, critical care and paediatrics. And then we have 8 new theatres at Poole, which are nearing completion, due to complete in spring. They're on time. We have our new Dorset Pathology Hub, which is not just for UHD, that's for the whole of Dorset. State-of-the-art diagnostics, really, blood tests and pathology test results. And then we're planning a new modular build as well, just outside here, which will give us some more wards here and new catering facilities so we can provide all the other facilities that patients need to get well. So just wanted to say really that in my mind, I'm always saying it's not about the buildings. I'm excited we're having those buildings. I'm pleased we've got the money because it's really creating great new facilities, and it's enabled us, for example, to, as we've said, have more single rooms and enable partners to stay with mums who've just given birth. But really it's about our people and our people that are creating those great pathways of care for patients. And we have brought together now all of our maternity services at Poole Hospital to enable them to continue working as one team with integrated care to get their pathways working before they move over here to Bournemouth. And it's really enabled a better, I think, better continuity of care for mums. And just so as an example, if a mum comes up for an antenatal review or has a concern and they need some extra care, they can get that all now at the maternity hospital. Whoops. So I put the other thing up. This shows it more accurate, really. It's a bit of a long and winding road, really complex, and I wrote some wonderful notes, which I always just go completely off piste, but what I was gonna say. So yeah, we've got our several funding sources, hugely complex, but we're just really keen that all of our sort of support network, really, not just our staff, but all of our community of governors, patients, volunteers and the ICS understand what's happening. And as Siobhan said, we're working much more closely with colleagues in primary care to ensure that our plans don't just work for us and our patients, but work more broadly in the wider system. So I'm going to ask Harry now to give a bit more detail on ED.
Thank you. Hello, can you hear me at the back? Hello, my name's Harry Adlington, or Dr. Harry Adlington. I'm one of the A&E consultants, and I have the pleasure of working at both Poole and at Bournemouth in the emergency departments there. And I'm the current clinical director, so it's my job to get us all into the new building, okay, in a safe and timely way. So I wanted to talk to you a lot today about the way forward for our emergency services. So first of all, when did this all start? So it all started back in 2017 when the Clinical Services Review made its decision. And at that point, it was Bournemouth that would be the major emergency hospital, and Poole would be the planned care site. And the drawings for the new ED were already in development, but at this stage, they started to take real pace and shape. So what we had was focus groups of clinical professionals guided by a dedicated design team that put in over 12,000 clinical hours into developing the drawing plans that you see in front of you. And in the photos that you see up here, you see the clinical teams as they're going through these plans under more scrutiny. As well as all the hours that went in, there was multiple visits to multiple other emergency departments around the country and hospitals around the country that were earmarked as current best practice. So we could learn how the environment could help support the patients in the best possible way. And what we did was bring all this back together to put this down on paper so we could see what we could try and achieve. And then once all the plans were down on paper, we went through each individual area again to scrutinise it in more depth so that we could reassess and redesign at that phase. Okay, so what did we actually get? So in our new department, what we see here in the emergency department is some key areas. So in the bricks and mortar, so what we actually get in the new building, first of all, the size of the new department is more than twice the size of both current departments combined. So we have got a massive space. So that works out 4,300 meters squared. When you put it into Google, it's about 2/3 of a football pitch, but that is a really big space. So the challenge for you, if you want to see how big it actually is, go out to the site and walk from one end to the other, and then you'll see how big it actually is and how long it takes. Because that's what I'm going to have to do if I go and do a ward round in that time. Okay. So the big things that we've got a single walk-in entrance. That sounds really, really like a simple thing, but now we've got one place where the patients know how to get into the emergency department. If you look at what we've got at the current Bournemouth site at the moment, it's a little bit chaotic because you've got different options that you can access the emergency department due to the changes that we had to put in COVID. But we're going to have an environment that's built so that patients don't have to choose which entrance they go in. They just go in the one entrance. So that makes things a lot more simple. We've got a rapid assessment and treatment area, and we call this RATS. And if I'm being honest, I don't like the term RATS because it's got like negative connotation, but that's what it's known at around the country. So that's what we've got to use. But what this means is it allows access to a specialist front door clinician. So that means a senior ED doctor that can at that point early on in your patient journey decide whether you need any time critical interventions or investigations and get those started straight away. So that is a good thing. Okay, so that we can start the journey a lot earlier.
Obviously the ground floor of the building.
So this is as you look at the front at the moment. So the ambulances are going to arrive around this bit here. So that's the walkway. Yeah. So spoiler alert, I'm going to give you a little virtual tour later where you can have a look inside the building. Okay. So this is the single site entrance where you walk in, and this is where the ambulances come in. And this is where along the road is where you'd look at it from the front at the moment. Okay. So as well as the RATS area, we're going to have a resus, and we're going to have a massive resus. We're going to have an 8-bedded bespoke state-of-the-art resuscitation bay so that we can look after all the patients with their critical injuries and critical medical needs in the most advanced ways that we can. Okay. There's some other things we're going to do. There's some first times for us here. So for the first time, we're going to have a dedicated space for children in the children's emergency assessment area so that they can be assessed by a specialist team of paediatric nurses and paediatric doctors. So these are clinicians that have undergone extra education and training so they can look after paediatric patients specifically. Okay. We're also going to have an urgent treatment centre, co-located facility, so that GP and primary care workforce can come and sit alongside the ED clinical practitioners so we can best help meet the needs of our patients. Because we know as the emergency department, we've seen how busy it is out there. We can't do it all on our own. We do need help from our friends. And that's what we're keen to get involved with. Again, this is another first time, and this is really important for me. And I've seen how this has affected our care over the last 5-10 years. We're going to have in-house dedicated imaging services of X-ray and CT. So before, currently at both sites, our CTs do not sit within our emergency departments. The simple thing of bringing the CT scanner into the emergency department, I mean, those critically ill and injured patients can go straight from resus, 10 foot to the CT scanner and 10 foot back. So that's going to change the way that we deal with critically injured patients and critically ill patients, for example, your strokes and your major traumas. So we can try and set up a service where rather than going to resus, actually we go straight to radiology, come back and then get the results through from there, which they're already doing at many major trauma centres. And us as a trauma unit, being able to do that is going to be really, really, it's going to be cool for patients. And then there's the ED majors. So this is a 26-bedded majors area, incorporating a fit to sit area and also a bespoke mental health assessment rooms, not just one, rooms too, but still rooms, which is something that what we know and what we've seen is our mental health patients have increased significantly over the last couple of years. And so this is a resource that is ultimately valued by them and something that we need to address. So these are real big changes, and this ED majors area is going to be like, I term it the workhorse of the emergency department. We're going to see all those critically ill and injured patients, okay? But it's not all about Bournemouth, okay? The future's bright for Poole as well. So as well as developing the planned emergency hospital on the Bournemouth site, we've also been developing the urgent treatment centre on the Poole site. Okay, and this was always going to be our model. Okay, and what we anticipate is that the urgent treatment centre, which will be based in the ED facility that's currently there on the Poole site, will see approximately 50,000 patients a year. Okay, so that's with minor injuries and minor illness. So a lot of the patients that currently walk into Poole with an injury or an illness will still be able to treat it at Poole. Okay, we need the urgent treatment centre to work on the Poole site, because otherwise the Bournemouth site will be swamped. So we've got a vested interest in making sure we can keep the care local for the people of Poole on that urgent treatment centre. Right, so I can tell you, sit up here and tell you how cool it's going to be because we have a brand new building and we're all really excited about it. But what you really want to know as the public is how long is it going to take to get there and how much is the parking going to cost? Okay, I can't answer the parking bit, but I can tell you how long it's going to get there. So as part of our plans, when we were looking which site we're going to do, SWAST, our partners in the pre-hospital team, undertook a 3-month review of every patient journey in their patch that came to the Poole or to the Bournemouth site. They then put those, so if we put our national UTC criteria and our national emergency department with the criteria that we're going to be using into that model, we can then see how that affects patient journeys. And the outcome for that, the weighted, so the average increase in patient journey was 1 minute, okay? But you're going to say, but what if I live in Swanage? I've still got to come miles all the way over past Poole. Well, I'll come on to that as well. So it's not just about the time it takes you to get there. It depends on what the condition that you have is. And where actually, if I'm being honest, the time to transfer of a patient to the hospital is not the key. It's, is there an emergency paramedic crew that are suitably trained that is available to respond to your immediate life-threatening problem? Because that's the bigger issue. So how far you've got to transfer the patient after they've done their bit is actually a moot point. So if you're at Swanage and you have a cardiac arrest, you want an ambulance with you. You don't care if it's half an hour or 45 minutes back to that hospital. You want that ambulance there with you as soon as it can be. And that's why, as part of our plans that we're doing, is so that we can offload the ambulances in a quicker time as possible. And that's what we want. We want to get ambulances back on the road so they can respond to patients, because we know the sooner they respond to patients, the less sick they're going to get before they bring them in. So it all works for us, okay? Just to put in context, so we've talked about 1 minute. When we talk about our major trauma patients, so we are part of the Wessex Major Trauma Network. So if we have a patient that is severely injured, so these patients are the sickest trauma patients that you can get. If they don't have an immediate airway or life-threatening problem, we make a decision. If we can transfer them to Southampton Hospital within 1 hour, we know it's better to do that longer transfer because ultimately they're in the right place at the right time first time. And that's the principle we've tried to put into this. We want to get patients to the right place, the right time, the first time, okay? So to show a couple of examples of that, I've got a few patient stories. So this is Rory, and these are all based on loosely on patients that have come through both emergency departments. We got Rory, he's a 12-year-old. He's down the skate park with his friends and he's accidentally fallen over and injured himself and he's got a poorly tummy. The thing about Rory is his parents have picked him up and they've taken him to the nearest emergency department, which is Bournemouth Hospital, okay? And that's what 2/3 of paediatric patients under major trauma do. They're picked up by the nearest and dearest and just taken to the nearest hospital. So the team, he comes into Poole and he's assessed, and he comes into Bournemouth and the team assess him and they think, yes, we are worried, you've got some bleeding in your tummy going on, okay? But here's our quandary. Our paediatric team is at Poole, our paediatric surgeons are in Southampton, and the Bournemouth site, which currently doesn't see as many children, is less familiar with doing the scans and then interpreting them. And these scans don't happen that often, but when they do, they're really important and really serious. So you can see, do we send him to Poole? If he deteriorates, he's got to go to Southampton. So in some ways, if our emergency hospital is actually nearer to our tertiary hospital for all those support, and it's not just the paediatrics I'm on about hospital, you can see actually, even if you come from Swanage to the emergency hospital, if you need that ultimate ongoing care, like you've got a serious head injury and you need to go to Southampton, you're that much nearer to there further down the line. Okay, so Rory's just one case. Also got John. John is 63 years old and he's lost consciousness while he's been driving, and he's been involved in a road traffic accident somewhere near Swanage, and he's complaining of back pain. So he's been assessed and the team have brought him to Poole Hospital because currently they are the major trauma unit. Okay. However, when the team come in and assess him, the RATS team that come and assess him early on, they find out that the pain actually started before he crashed his car and lost consciousness. And so they start to think, actually, I'm worried this might not be trauma. This might be that you have an aneurysm in your abdomen, an aortic aneurysm that might be ready to rupture. And so they've done some bedside tests that confirm this. Now, he's in Poole in the major trauma unit, but what he needs is a time critical emergency operation under the vascular team. And I think you know which way this is going. The vascular team are currently at Bournemouth Hospital. So he's then got another critical care transfer, which adds to a delay into the system that he needs to go through. Another scenario, not to hammer out the point, but Mary, she's 73. She's from Christchurch and she's fallen off her bike and may have hit her head. She's assessed by the paramedic crew and they've taken her to Poole. So she's come past Bournemouth to go to Poole because that's the major trauma centre and it might be head injury. Again, when the clinician is assessing, it becomes a little bit clear that there's some weakness in her arm and some weakness in the leg. And actually they think, I don't think the head injury was the first thing. I think this lady might have had a stroke before falling off her bike and that's what's caused her to fall. So they have a CT scan which confirms she's got a stroke. And at this moment in time, she's in the window for stroke thrombolysis. So the clot busting drug that can get ready to really help and treat you when you've got a stroke. But you've guessed it. The stroke specialist is on the Bournemouth site, which is what that patient has originally driven past to get to the Poole site. So this is the situation with that. And those are 3 examples that illustrate the point, but they're not just made up examples, they're based on real life. And this happens quite regularly. So we might get the patient coming to an emergency department, but actually when we've got more clinical information or we've got a witness statement or we've got more general information, we now know that actually you're ultimately in the wrong hospital and we need to get you to the other one. And if you look at those ambulances are now racked up outside of EDs on both sides, getting that patient transferred is now much more a problem than it used to be. It's not just a matter of ringing up and saying, I've got this urgent patient. You are then in the priority list of the queue of patients that are all waiting ambulances around the region. Okay. So I know I'm labouring the point a little bit, but what I'm really wanting to get to do is what you want to know is where are we at the moment? So what all these stories demonstrate is at the moment, key specialist services are split and divided across both sites, which means there is a need for emergency transfers between both sites ongoing on a daily basis. So if we have a look at what could happen when we have our big move, okay, we're going to have one emergency team for East Dorset in one new emergency department. Yeah, it's going to be twice as large as both departments combined, but what's more important, the first time we're going to have all the experts in one place. We're going to have all the emergency patients travelling to one place, okay? We're going to have all the ambulances, they don't need to make a decision. Do I take you to Poole? Do I take you to Bournemouth? Based on my limited information that I've available at the time, they're just going to take you as an emergency to the one place. Okay. And this then lets us improve access to consultants and specialists on the emergency site 7 days a week. And it's the same with improved access to the emergency diagnostics and interventions like the CT scanner, again, 7 days a week. So I'm trying to convince you, I hope I have. But now I've got the pleasure of just taking you on a little journey so I can show you what it looks like actually inside the new department with a virtual tour. Okay.
Hello, I'm Dr Farhad Islam. I'm a consultant in the emergency department at University Hospitals Dorset. It's really exciting for all our staff to now see that the enabling works have already started to create the new access road for the site. This brief animation shows how we plan to develop the new emergency department at the Royal Bournemouth Hospital site. This is part of the major £250 million transformation of our services at University Hospitals Dorset, including developing a 24/7 urgent treatment centre at Poole Hospital. These changes have been planned over the last 4 years with regular input from local clinicians and the public contributing to designing a state-of-the-art bespoke modern emergency department. This conforms to new national standards fit for the future needs of our local population in East Dorset and beyond. We start with a view of the covered ambulance drop-off area, moving towards the ambulance entrance of our new emergency department. This will be larger in size than both the existing departments at Poole and Royal Bournemouth put together, and will include an expanded resus area with direct access to adjacent CT scanning facilities. This will facilitate timely diagnosis for some of the sickest patients that present to our new ED. As we move into the building, you can see the nurse streaming desk used to direct ambulance teams to the correct location, and then through the doors into the resuscitation area. This area has 8 large resus cubicles with 2 paediatric enabled rooms immediately adjacent to the new paediatric emergency department and urgent treatment centre. Each resus bay is double the size of our current resus bays and have access to the near patient testing facility provided for quick point of care diagnostic tests. There's also access to a medicines management room, near patient testing, as well as additional toilet facilities. Moving out of resus, we're now in one of the main arterial corridors, with the CT scanners directly opposite to resus and patient relative rooms passing on the right. You can also see the ambulance crew restroom in this area. We're now in the Rapid Access to Treatment area, or RATS for short. This space contains 7 clinical trolley spaces and 4 chair spaces. This will be a very busy area where initial decisions are made on patient condition by senior clinicians and patients sufficiently managed by multidisciplinary teams to ensure rapid and appropriate tests are ordered and initial treatments are commenced. You can also see what's known as a dirty utility room, an essential space to safely dispose of clinical waste and laundry. We're now moving out of RATS and back into the main arterial corridor. Again, you can see access doors to the right to various staff facilities, including flexible offices and a simulation training facility for all ED staff, washrooms and the new ED staff room. We now exit the building via one of the fire escapes to get another view of the exterior environment. Outside you can see more ambulance and emergency vehicle parking before we loop back to the view of the new building facade. For more information on this development and the future plans for Royal Bournemouth Hospital, visit the Investing in Our Hospitals section of our website.
What we want to get across is that all of our staff, so it's not just Harry and Izzy and his consultant colleagues, but all of our staff, both clinical and non-clinical, are really passionate about creating a new emergency and planned care hospital sites to sort of transform services to improve care for all our patients. And I think, I just see it that you are all not just members and governors, but patients, relatives, friends, as am I. I'm not just working here. I've got elderly parents, I've got children. I want the right care for them. And that's what we're all trying to create.